Chapter 9 is on joints, otherwise known as articulations. Three types of joints would be fibrous, cartilaginous, and synovial. Fibrous joints are joints where the bones are attached via fibrous connective tissue. Three types of fibrous joints would be sutures in the skull, a mature suture where the fibers are no longer present is often referred to as a synostosis. Syndesmoses would be examples such as the distal tibiofibular joint. Here the two bones are attached by ligaments, which are fibrous connective tissues. Finally, we have gymphoses, in which case it's actually the teeth that are attached to the alveolar sockets of the upper or lower jaw bones via the periodontal membrane. These fibrous joints are called gymphoses. Again, teeth to the alveolar margins are joints known as gymphoses. Second category of joints are held together by cartilage, therefore called cartilaginous joints. Depending on the type of cartilage that is present between the bones, we have either a synchondrosis, hyaline cartilage, or symphysis, fibrocartilage. Synchondroses may be temporary. In other words, they fuse over time. Examples would be the growth plates in long bones. These plates are known as epiphyseal plates. When they become changed into bone, replaced by bone, these plates are no longer present and they're known as epiphyseal lines. The only example of a permanent synchondrosis would be the first sternocostal joint. Recall, costa means rib. So this joint articulates the first rib through its costal cartilage to the manubrium of the sternum. All other sternocostal joints, inferior to the first one, are synovial, slightly movable joints in this case. In symphyses, the two bones are united by fibrocartilage. Examples would be the intervertebral discs that articulate between the bodies of vertebra, and the pubic symphysis, which joins the two pubic bones anteriorly to each other. Synovial joints are freely movable joints. The word for freely movable is diarthrosis. Major components of synovial joints would be articular cartilage, hyaline. This caps the two bones that are forming this joint. There is a joint cavity filled with synovial fluid, which helps to lubricate. The articular capsule has two parts. The outer component is the fibrous layer, which is continuous with the periosteum. Deep to the fibrous layer is the synovial membrane, which forms the egg-like synovial fluid. Ligaments further strengthen these synovial joints. There are other structures that are associated or may be associated with synovial joints. Bursa are bags of synovial fluid that help reduce friction, lessen friction, as shown in the shoulder joint diagram. Tendon sheaths are essentially elongated rolls or sheaths also with synovial fluid. In this diagrammatic, you could see the tendon sheath that surrounds one of the tendons of the biceps brachii muscle. The various movements possible at synovial joints, you should understand. This will help you a lot once we start learning the muscles. Flexion and extension. When you flex at a joint, you are decreasing the angle at that joint. Extension would be an increase in the angle of that joint. In adduction, you are moving a body part towards the midline. Abduction, away from the midline. Circumduction, you are describing the shape of a cone, like one of those orange cones at construction sites. Elevation and depression, self-explanatory. Lifting a body part up is to elevate. Bringing it back down is to depress. Protraction and retraction. Protraction, when you extend something out, protrude. Retract, put it back in anatomical position. Forearm may be pronated or supinated. When you rotate the forearm so that the palm faces anteriorly, that movement is called supination. When you rotate the forearm in the other direction from anatomical position to a posterior stance, that is known as pronation. Supination, palms forward. Pronation, palms posteriorly. Opposition, we could do with the thumb. We have opposable thumbs. The opposite would be reposition. E and F in this diagram refer to movements at the foot. When you bring the sole of the foot in, that's called inversion. Sole of the foot out is eversion. When you bring the foot or the back of the foot towards the shin, that's dorsiflexion. Perhaps it's easier to understand the word plantar flexion when you plant your foot down. Plantar flexion, foot down. Dorsiflexion, foot lifts up towards the shin. This chapter discusses in detail many synovial joints. The only joint that I will cover in detail, therefore the one for you to concentrate on, is the knee joint. It is a very complicated joint, and it's defined by many ligaments and other components. This anterior view of the knee joint shows the major ligaments in the front. That would be the patellar ligament. Remember, patella is the kneecap. The patellar ligament is a continuation of the quadriceps tendon. On either side, you have a collateral ligament located medially, running from the tibia, would be tibial or medial collateral ligament. On the lateral end, running from the fibula, would be the fibular or lateral collateral ligament. Posterior view of the knee will show the very large popliteal ligament that has two major components, the oblique and the arcuate components. Also in this posterior view, you could again see the two collateral ligaments. In this lateral view of the knee joint, and depicted in more of a green outline, would be the various bursa associated with the knee. Recall that bursae are bags of synovial fluid. There are probably close to a dozen different bursa associated with the knee joint. The one that is most often affected clinically, injuries because of falls and so forth, would be the subcutaneous, under the skin, prepatellar, in front of the patella, bursa. Please remember that, subcutaneous, prepatellar, bursa. In this diagram where the knee is flexed and the patella is reflected, we could see the two intracapsular ligaments, which would be the fibular and the tibial, which would be the anterior and posterior cruciate ligaments. You could also see the menisci, medial and lateral meniscus, which cushion and deepen the articular surface of the knee joint.